Thank you. Thank you so much, Digvijay, for inviting me for this course, and it's lovely to be part of it. So OCT has been now gaining some ground in its applications in various disorders of neuro-ophthalmology. So let's see how would you look at it. So if an OCT printout is given to you from the neuro-ophthalmic perspective, what exactly we are interested in? We are interested in RNFL thickness, and this is how the RNFL thickness average graph looks like. We are interested in peripapillary RNFL thickness graph. The most important is this average thickness, because that's what we will be looking at. In a neuro-ophthalmic disorders, especially in optic nerve disorder, in an acute phase, acute insult, most of the conditions will lead to some or impressive degree of optic nerve head edema, which will be reflected in increased thickness on OCT, increased thickness of RNFL on OCT. And if the disease process is unabated or not treated, it leads to RNFL loss, and that will be reflected as average RNFL thinning on OCT. So when this printout is given to you, the green is a normal thickness. Why do we say normal thickness? That means this is the thickness that we expect for that particular age. This is basically compared to age-matched control. But anything which is in yellow or red zone tells you that there is a thinning of RNFL. So this is this particular graph tells you whether there is. Here you can see that there is a thinning of RNFL in temporal, superior, and inferior quadrants of the right eye. While the left eye, in this quadrant, you find that it's all green. That means the RNFL thickness is fine, except maybe there is a little increased thickness here. The same would be reflected in the graphs here. You see here, this is the comparison between right eye and left eye, and clearly you can see that the right eye thickness is lower than the left eye. And here you can see the graph of the right eye, which is going down in the left eye and the right eye. You find here that corresponding areas, the graph is going down in the red and the yellow zone, telling you that there is thinning of average RNFL. So that's how you look at it. Now, how do you use this data? There are three main pillars. It can be used to prognosticate what would be the outcome of your intervention. It can be used in progression of the disorders, and we look at a case. And rarely it can help. It can be an adjunct to the diagnosis of certain conditions. What about prognosis? Helen Danishmar and Peter Savino published this paper a decade ago, where they did a preoperative OCT and they looked at average RNFL in patients who are undergoing neurosurgery for parachiasmal tumors. And they concluded that if the average RNFL thickness was thin, those patients had much less chance of improvement of vision or resolution of visual field defect versus somebody who had average RNFL thickness, which was more than 70 micron or so. So what it tells you, if you order OCT in somebody who is undergoing a neurosurgical procedure, and if average RNFL thickness is more than 70, there is a high chance that there will be improvement in his visual acuity and visual fields. The other concept, so that was peripapillary average RNFL. The newer concept, relatively newer thing to look at is GCC, or ganglion cell complex. It comprises of two layers, ganglion cell layer and inner plexiform layer. And this is how the map looks like. Now the newer machines will actually give you these maps together with the average RNFL map. Here, the cooler colors like blue color denotes thinning, while a warmer color like yellow denotes that it's a normal thickness of the GCC. And as you see here, this side, binasal macular side GCC are thin, which gets reflected into bitemporal heminopia. This is the patient with a chiasmal compression. And following surgery, this is around a year later, the visual field has resolved. Of course, there is no change in the GCC thickness. GCC is gaining ground as a much sensitive and an early indicator in a lot of instances. So chiasmal compression, it shows up. The thinning of GCC shows up even before visual field defect or even before loss of average RNFL. So this is an important use of OCT, both average RNFL and GCC. Use number two, this is a 28-year-old female with a picture which is suggestive of papilledema. How do we use OCT here? OCT can be used to give you an objective assessment of what is happening to your treatment. So patient comes to you, you do average RNFL, it will be increased because of disc edema. You follow the patient up and you see what's happening. Is there any decrease in average RNFL as patient undergoes a treatment with Diamox or surgical treatment? And it'll give you an objective assessment that yes, the optic disc edema is reducing, getting reflected in reduction of average RNFL. A word of caution, the RNFL can also reduce because the disease process basically is leading to death of the neurons. That will get reflected in GCC. So if you have thinning of average RNFL, but the GCC thickness is not affected, you know that your treatment is working. But if GCC also is getting thin in a subsequent OCT, you know that patient is actually losing its neurons. The other important indication or use of OCT is to differentiate between a true disc edema and a pseudo disc edema like drusen. So drusen, the internal contour of the disc will be lumpy, bumpy, while a true disc edema will have a smooth contour, which also will, this is again a reflection of papilledema causing a disruption of RPE and Brooks membrane. Another important use of OCT would be somebody who is coming for a general examination, a general ophthalmic evaluation, and suddenly you find that the optic disc, which looks a little suspicious. Of course, you would rely on the optic nerve function test, but OCT can also help you here. If the same patient has a thinning, then you know that patient had some insult which led to neuronal loss in that eye. There are other uses of OCT like optic neuritis can show increase in average RNFL if patient has papillitis, which will subsequently reduce. In a multiple sclerosis, even in a subclinical or no clinically overt optic neuritis, patient can still have thinning of average RNFL. AIN will have a sectoral thinning and thickening. Other optic neuropathies again will show corresponding average RNFL. Neurodegenerative disorders like Alzheimer's disease and Parkinsonism shows thinning of RNFL, and it can probably in the future be used as a biomarker of these disorders. Word of caution, children, we don't have a proper data to use it with confidence. And even in no PLI, you'll have some amount of RNFL thickness up to 30 or 40 because of presence of glial cells. So OCT can be an adjunct in neuroophthalmology. It is still not reached the stage where it can be used as a substitute for a standard protocol. Thank you so much, Vijay.